All right. Good afternoon, everybody. For those of you who don't know, my name is Peyton, and I am the outreach coordinator at NAMI Greater Cleveland. This webinar is going to be recorded and uploaded to our NAMI Greater Cleveland YouTube page, hopefully within the next week or so. I ask that you remain muted throughout the presentation so that we avoid any background noise. But feel free to utilize the chat if you have any questions. I'll be monitoring throughout, but we'll also have time at the end of the presentation for questions as well. And this webinar is eligible for one CEU for counselors and social workers and marriage and family therapists. So at the end of this presentation, I'm going to be sharing a link to our evaluation so that you're able to provide your name, email address, and license type and number in the evaluation so you can receive that CEU. And if you're just here without the CEU, I would still really appreciate if you could fill out um, the survey so that we are aware of your honest feedback and can continue to provide what the community is looking for. So, if anybody is new here, just a quick overview of NAMI. So, here at NAMI, or the National Alliance on Mental Illness of Greater Cleveland, our mission is dedicated to empowering those living with mental illness and their family members so they're able to achieve a better quality of life by providing education, support, information, referral, and advocacy. So we provide support groups, education courses, and other opportunities for people who are living with mental illness, their family members, and their loved ones as well, and community education programs on special topics like this one. We also provide a helpline that's staffed from 9 a.m. to 9 p.m. Mondays through Thursdays and 9 a.m. to 5 p.m. on Friday, where our trained staff and volunteers can provide assistance with locating resources related to the mental health and other community resources. So I will share the helpline number and the link to our website in our chat. So if you have any other questions regarding our services, you can check there. But I will go ahead and pass it on to our presenter for the day, Maddie, and we will go ahead and get started. Thank you so much.
Cool. Thank you, Peyton. Good to see you all. I am going to share my screen if it'll let me. Ooh, there we go. We can all see that, right?
Yeah.
Excellent. Okay, so thank you all for joining us. My name is Maddie. I will introduce myself a little bit. Today's topic that we're going to be presenting on. Oh, Cassie raised her hand. What's up? For those who don't know, Cassie, oh, there we go, is my wonderful colleague at NAMI Greater Cleveland. So if I see her hand go up, I'm like, oh, what's going on? Do I need to pay attention to something? Anyways, today we're going to be talking about mental health and disability, which is a very broad topic. So my hope is that we can hone it in a little bit and talk about a few key elements of this intersection. So we're going to talk about key terms in the mental health world and the disability world at the intersection of mental health and disability. We're also going to talk about mental health conditions as a disability, as they are for some people. We will talk a little bit about the impact on daily life for people with mental health disabilities. And we're also going to talk about resources available in Northeast Ohio, since I know that most of us here are local, and it's always good to know what's going on in our neck of the woods. So first, you should probably know who is talking to you today. My name is Maddie. I use she, her pronouns. I'm a therapist in solo private practice. You can't really see, but that's where I am today. I'm in Cleveland Heights. I've been a social worker for 9 years now. I graduated with my master's from Case in 2019, and I have some special trainings that are tangentially relevant to today's topic. I have a certificate in sexual health from the University of Michigan, and I have training in perinatal mental health. So, uh, trying to conceive pregnancy, postpartum, parenting, all of that stuff. And yeah, obviously, those are two really huge fields. And so I do see a lot of folks with mental health disabilities and disabilities that impact their mental health. So that's a little bit about me. Let's dive into what we're talking about today. So, first things first, probably for many of the folks here, especially those who are seeking a CE, you are well aware of what mental health is, but I think it does bear an introduction for those of us who maybe aren't quite so sure. Mental health is a term that I think gets used a lot and often in really like indiscreet ways, like really vague ways. So when I talk about mental health in this presentation, I'm talking about not just emotional well-being, but also psychological and social well-being. And this is a definition that I'm taking from the National Institute of Health. Mental health is more than just the absence of mental illness. It's more than just, I'm not depressed, I'm not anxious, I'm not struggling. It's more than just our personal choices. It's more than, taking medication, going to therapy, exercising, eating healthy. It's impacted by a lot of different factors. So, for the social workers in the room, you're probably very familiar with this illustration here on my right. This is a theoretical model that we use called Bronfenbrenner's bioecological systems theory. And don't worry, there will not be a quiz at the end. This is just a theory that I like to use to kind of ground these presentations in. Um, you can see that at the middle of this diagram, we have our little stick friend. And this is a person, clearly. And as the rings get further and further out, each ring represents a different level of influence and how impactful that influence is on that person. So you can see that this person and their mental health at the center is really closely and significantly impacted by their peers, their workplace, their family, their faith, their physical health, and the care that they're receiving from medical and mental health practitioners. And then as we get further and further out, things like media, the environment, the community that you live in, what resources are available. And even further out in the macro system, there's things like at the structural level. This can include things like what ideologies, what schools of thought, what cultures exist in your community, what is the economic structure. All of these things from a really high level all the way down to an individual person to person level can impact your mental health. So, in short, if you take anything away from this very, very wordy slide, it's that when we're talking about mental health today, we're talking about not just one thing. We're talking about a really multifaceted thing. So, when we talk about mental health, we also talk about mental illness. Um, in this presentation, I'll be kind of differentiating between any mental illness and severe mental illness. So, any mental illness is kind of a broad umbrella. Any mental illness includes any social, behavioral, or emotional disorder. Severe mental illness is a little more specific. It results in pretty serious functional impairment, meaning your day to day life is really impacted. And this can look a lot of different ways. So, severe mental illness is, you know, uh, a mental illness that is, as we'll talk about in this presentation, often disabling. It often keeps someone from being able to function the way that they normally would if they were not struggling with this mental illness, or it keeps them trapped in I guess, like stuck in a pattern that isn't working for them. And often this is a chronic condition. An AMI, any mental illness, is something that might be time limited or improves really rapidly when treated. Severe mental illness is something that might come and go in waves. Somebody might be living with it for a very long time. So this presentation is about mental health and disability. So we should define disability as well. The CDC defines disability as any condition of the body or mind that makes it difficult for a person to do certain activities and interact with the world around them. Often, when we think of disabilities, we first think of this logo here on the right, which is often used to denote, accessibility in locations. So, like accessible parking spots, elevators, ADA compliant bathrooms at public places, things like that. But sometimes, and actually quite often, as we'll get into later, disabilities are not quite so visible. They're not something that we can see with our eyes, and that doesn't make them any less valid. Under the Americans with Disabilities Act, there's also a legal definition of disability as well. That would, ooh, someone's annotating. Fun. Under that legal definition, disability is considered a disability is something that causes impairment to one or more major life activities. So this would be, somebody who struggles to perform the things that they need to do in daily life. They're not able to care for themselves as somebody without that disability would. They're not able to live as independently as someone who is not disabled. They're not able to access public spaces or resources the way that somebody who is not disabled would. So again, just like mental health, disability is a really broad category. And I wish that my chart would show up here, but that's okay. Um, Mental health as a disability really is encompassing primarily SMI, severe mental illness. So what is missing over here on the left is a bar graph that kind of puts into perspective the prevalence of mental health disabilities. But I can just tell you about it too. Our most recent data from the National Institute of Health shows that in a survey conducted in 2022, an estimated 15.4 million Americans suffered from severe mental illness. That proportion was slightly higher in women than men. The largest group was people ages 18 to 25. And the prevalence of mental health disabilities was most common among people who self identified in their surveys as two or more races. So, why do I include all of this prevalence data? One, to show you how common disability is in our culture, in our society, and also how it doesn't always look the way that we think it looks, or sometimes it doesn't look like anything at all. We can't see it. Um, I also include this data about age and race because I think that it is really interesting how we think about those things, how we think about mental health disabilities, and how that's influenced by our culture, by certain beliefs that our families of origin hold. And I hear a lot from clients that in the younger generations, among millennials, Gen Z, Gen Alpha, even, uh, mental illness carries less stigma than in older generations. We have more of a cultural conversation in these age groups about mental health. And so when we see these big national surveys done and then broken down by age, it does make sense that young folks who are more comfortable talking about their mental health might be more likely to identify this way. Okay. So we talked about disability. We should also define what even is ability. When we talk about ability, we're saying this is somebody who is able to perform specific tasks, participate in life roles, and adapt to changing conditions. So I am able to walk without any mobility assistance. Some people view this as temporary, that, as we age, as our bodies change, as time goes on, we might not always be able. And the reason that I bring this up is that uh, often our world and our society is built for people who are, in most ways, able, who do not have a disability. So right now, I have no problem getting up the 2 flights of stairs to my office. But somebody who is older, somebody who has a disability, might not be able to do that. That's why we have an elevator in my building. That's why, for me as a therapist, it was important to have a space that all my clients could get to. Um, and again, we'll talk more about how the environment plays a role a little bit later. So, a note on language. You'll hear me talk about disability in a few different ways. Some people prefer person first language, for example, saying a person with a disability. Other people really prefer saying disabled person. There is uh, like a real line of personal preference here. There isn't as far as I am aware, a recognized best practice when it comes to terminology. I have heard clients and I have heard other presenters say that person first language is not how people want to be referred to, that disabled as an identity is something that disabled people are really comfortable with. For example, those with hearing loss or those in the deaf community would much rather be called deaf than be called person with hearing loss or person who is deaf. Um, if you're working with clients or you meet a new person who has a disability, I would encourage you to take your cues from them. How do they refer to themselves and their community and the people that they're in conversation with? So you'll hear me use a few different things throughout this presentation, and that's intentional. Definitely open to feedback as well. So in assessing disability, we have this thing called dimensions of disability. What this means is we are looking at uh, how does that disability show up in a person's life, and in what areas of their life does it show up. So this kind of harkens back to the Bronfenbrenner's diagram that you saw on one of the first slides. So one of the dimensions of disability is impairment. So in what areas of that person's body or mind are they impaired? This might include multiple dimensions, multiple impairments. For example, in neurodegenerative disorders like Parkinson's, people have both physical and mental symptoms or impairments. A person might also have activity limitations, so difficulty with things like seeing, hearing, walking, problem solving. And again, these might be limitations on physical tasks. It might be cognitive tasks, thinking tasks. It could be a combination of both. And we're assessing participation restrictions. So we're assessing, how is this person able to work? How are they able to live? How are they engaging in their social life, in recreation? And also, are they restricted from being able to obtain healthcare? I gave you the example of the stairs and the elevator in my office building, which is a medical building, just because it was the first one that came to mind. But if we think about it, there are probably lots of spaces that are physically restrictive for someone trying to obtain healthcare. In this presentation, we're talking about mental health disability. And so we're also thinking about what expectations or what structures in obtaining healthcare might be inaccessible to somebody with a mental health disability. For example, um, many years ago, I used to work in a community mental health agency, and we had walk in appointments. So if you wanted to become a new client, you just had to show up anytime between 8 and noon. And, in the order that people arrived, they would be taken back with an intake assessment person and they would do their intake. Um, the thing that is tricky about this is that as a community mental health agency, we primarily served people with severe mental illness or mental health disabilities, and the impairment of their disability made it difficult for them to access that walk-in appointment. And you might be thinking, oh, like all you have to do is walk in, all you have to do is show up. How is that so hard? And honestly, I thought like that too when I was a new social worker and started working there. What made that hard for those folks is that they were impaired in areas like executive function. So, keeping track of or organizing information. They were impaired sometimes cognitively. If my short term memory isn't functioning the way that it should, then how am I going to remember, is it a left turn or a right turn to get to that office building? Or what time does the bus come? Um, if I'm impaired in terms of like my orientation to reality, if I have severe schizophrenia or another psychotic disorder, I might not be oriented enough to even get myself to the bus stop, let alone get myself to the appointment, let alone fill out the 15 forms on a clipboard that we have for people. And yes, like a lot of these processes exist for a reason, and I'm not denying that. But it also does matter that we're thinking about to whom are they inaccessible? To whom are we not meeting? Like, who are we missing when we are setting up these processes and these services? So, the intersection of mental health and disability is an important thing to consider. The examples that we were just talking about are examples where somebody's impairment keeps them from accessing mental health treatment, but there are a lot more examples of this activity restriction or participation restriction than just accessing healthcare. If somebody is struggling with executive dysfunction, we can stick with that one. It might be tough for them to not only keep track of their appointments, to organize their medications, to remember to take those medications, but also it can be difficult to do things that are pretty basic to our well being, like hold down a job, pay bills, wash dishes, wash clothes. Um, Care for any loved ones, whether they have children or are caregiving for someone else or pets, even. So sometimes when clients are coming in and they are really in a tough spot, when they are really struggling with their activities of daily living, one of the first things that we should be considering and looking for is how does your mental health impact your ability to do that? Rather than saying, this person is medication non-compliant or they have missed 5 appointments, so that means that they need to be discharged. That might be your agency's policy, but also we need to be considering, did we set them up for success with this? Um, if I'm, and again, I'm speaking from a place of like pretty extreme privilege right now because I'm a solo private practitioner. So I have my own set of policies and things. But um, if I say, all right, 2 strikes and you're out when it comes to missing appointments, am I then cutting myself off from being able to really partner with my clients with mental health disabilities? Maybe that's something for me to think about. Maybe that's something to get the wheels turning for you too. So, how prevalent is this? I've given you a bunch of kind of one off examples, but is this a thing that we're all going to be seeing? The answer is yes. uh, According to data from the World Health Organization, about 16% of our global population has any disability, whether physical, mental, combination. And they give the example of a few different contributing factors to this disability prevalence. Number one, our global population is aging, which at face value is a good thing. I mean, our lifespans are longer, medicine is more advanced, we are able to live into old age, but also rates of disability increase with age. We know this. We know that as our bodies get older and as our brains get older, we start to have more impairment. Um, this really raises the question of and I'm getting like a little heady here, so stick with me. What's considered a disability and why? If our world is built for young, able bodied, able minded people, then of course, anybody who doesn't fit that mold is going to be considered disabled. But if people are often living into old age, does that mean that our world needs to change and adapt to meet that demand? Another contributing factor that the WHO identified was increased prevalence of non-communicable diseases. So these are not infectious diseases like uh, infections, things like that. Non-communicable diseases includes things like Alzheimer's, Parkinson's. Um, why am I not thinking of other things? Cancer. Really, again, as our world changes, we not only have greater prevalence of these diseases that before we did not see as often, but also we have better screening for these diseases. And so people are able to uh, get treatment sooner if they're able to access it. That does mean that they are able to live and survive with these communicable or non communicable diseases. But often having these conditions does leave a lasting impact. So somebody might have a limb amputation after cancer treatment. Somebody might have brain fog after undergoing Parkinson's treatment. Somebody might be able to live for a very long time with something like Alzheimer's. But again, that does mean that they're counted in this statistic of how prevalent is disability overall. And lastly, and this is the one that I've been like hitting the hardest in this presentation, um, this prevalence rate includes the interaction of a disabling condition with both personal and environmental factors. So, what that means is uh, when somebody has a condition like schizophrenia, um, at face value or at the most basic level, um, that condition doesn't have to be disabling. Like if we think about it in a vacuum, which I know it's not, um, that condition is simply a set of symptoms. What makes that most challenging, what makes that most disabling, is often the factors that come with it. So things like inaccessible transportation, um, long wait times for healthcare, systems that are not set up for a person with that disability, as well as the financial strain and limited social support that comes with these conditions. So if having schizophrenia makes it difficult for a person to hold down a job, pay bills, save money, if they're having frequent unexpected hospitalizations, all of those things impact their ability to live independently and live well. And especially when it comes to mental health disorders as well, a lot of people with disabilities struggle to have strong social support systems. Part of this, and we touched on this in a different NAMI webinar a while back, talking about, oh gosh, I think it was one of the Dr. Amador communication webinars. Um, Sometimes mental health disabilities come with something called anosognosia, which is, again, you don't need to remember that for a quiz later. All it means is um, a person who doesn't have awareness of their mental illness, that they are not aware of how a mental, emotional, or cognitive impairment is impacting them. Um, it can be really hard to be a loved one of somebody who doesn't know how much their illness is impacting them. It's really difficult to show up for that person because they might not realize that you're trying to help, or they might even try to push you away, or they might do things that to you seem like self sabotage. And again, part of this is that rub with the systemic factors of how am I supposed to show up for you when I only have so much that I can give? There are only so many resources that I can offer. There are only so many things available. Um, so again, in a vacuum, these conditions, not on their face something that would necessarily disable a person. Sometimes it's the environment. Sometimes it's those factors that amplify the impairment that they're experiencing. So, did you know we have an estimate from the WHO that 1.3 billion people are disabled worldwide? If that is surprising to you, feel free to, I don't know, throw up one of those little emojis in the chat. If it's not, then kudos to you. You really know your statistics. I found this surprising when I gave this presentation the first time. Um, Really, I point this out because it stands out that disability is a much broader category than we're taught to believe. Okay, I think this is where I have a little video clip for you, but I don't know if it's going to play. I'm hopeful that it will. These are two disability activists, and they are going to be talking about kind of what we touched on the last slide. So let's take a minute and just listen.
So if you and I go to a building and there's no ramp, typically people think the problem is that we use wheelchairs, where a social model of disability would say the problem is that the building's inaccessible. And it doesn't seem like a radical concept, but it changes the fundamental way we think about disability and the work that we need to do to include people with disabilities.
People often don't understand ability to be within this kind of context and access to adaptive devices and where we are located economically. When I have my access needs met, I'm functionally not disabled. But when places have stairs and everything is built for people that stand, so I can't see anything, and it's a really dark environment, I can't see anything, because as you get older, your vision changes. So now I need a lot of light to see things. In an environment like that, of course, I'm disabled.
I really like separating out impairment from disability. So impairment as like physical or neurological manifestation, like what's real. I have a physical impairment. And then disability is like what society creates as barriers because of the impairment. So like, as you're saying, if we're in a place where my access needs are getting met, then my impairment isn't so significant. But when it's not because society doesn't want to, then that's a problem. So I think it's important to really think about disability and the context of what is disabling, like the environment. The last building I worked in, it was really cool because it was universally designed. So all the doors had push buttons, or they're like magically open, as you walk up, or everything is like automatically at my height. And in that place, I didn't need a lot of accommodations. But then in an environment where it's not universally accessible, where people with disabilities and parents and all types of folks weren't thought of in the design process, that's when there's problems.
I'm not saying like it's easy to live with an impairment. It's not easy to live, you know, when you have like 4 kids. It's not easy to live when it's like 20 degrees outside. I mean, you know, for those of us in the Bay Area, 55 is freezing. But you know, I mean, there are times when it's just not convenient to have a body, but that's not what oppresses us. What oppresses us is living in a system that disregards us, is violent toward us, you know, essentially wants to subjugate our bodies or kill us. That's oppressive. My body doesn't oppress me. My body's fun, but society, that can be incredibly oppressive.
I think when we focus on a person's individual impairment or diagnoses, as you said, it kind of like lets society off the hook. It makes all the focus on that individual circumstance when really ableism and exclusion and violence happen because of systems of oppression. So we know it's not like an individual person with a disability that's the issue, but we can look at the way, for example, with policing, victims of police violence are 50% people with disabilities, if not more. Or if we look at the special education system, it's not the individual special education student, but we can see how special education becomes continued segregation for so many Black and Brown students. So when we focus on like the individual impairment, it kind of takes away from that bigger picture.
We're seen as disposable because for those of us that are not going to have like a treatment or a cure with our bodies, and we kind of fly in the face of this idea of medicine as God. We're seen as less than, and you're awesome, you're fabulous, and you are beautiful, and how could the idea that someone would think that you're less than is just absurd. And yet that's like the framework that we're in. Yeah. And it's incredibly painful. There are always going to be crips. There are always going to be, you know, people in pain. It's just the nature of being in a body. But the social body we can change. And I think it requires a power analysis.
Okay. I loved seeing some activity in the chat while we watched this. Check that out when you get a chance. So a couple things always stand out to me when I play this video for people. One is when Patty, the woman on the left, says that she rejects the idea that medicine is God. To me, that really represents how, for a lot of people with disabilities, there is no end point. There is no cure. And so this is a lifelong journey. This is a lifelong experience of how does the way that I am as a person impact how I move through the world? And then what Stacy kind of lifts up in tandem is the world may not necessarily be built for me, and that impacts the way that I live throughout my life. They said that to them, impairment is what's real, and disability is what society creates, often through the environment. And I love this quote: when my access needs are met, my impairment isn't so significant. I really like this video and this video series. It's through Barnard College. If you want to see more, it's all on YouTube. I really like it because, one, I think that when we talk about disabilities, we should be listening to disabled people. You know, nothing about us without us. And also, I think that it really sheds light on the mental health impact of having a disability. So imagine now that you are in that situation that Patty described. You go somewhere and you can't see anything because you're low to the ground and it's up high. There are people standing in your way. There's nowhere to sit. It's dark. It's noisy. If you have any type of sensory processing issue, uh, that's going to be incredibly overwhelming. Now imagine that that's every day. Often what I talk about with clients who are disabled is both how can I get my access needs met, and also how can I process the grief that comes up around living in a world that isn't built for me. And a lot of this therapeutically is grief work. Um, we all have human needs and human desires, and one of them is a sense of belonging. It's really hard to foster that in a world that feels hostile. So, what are some common needs that disabled folks might have? Again, this is a very broad list. I do not pretend to know what every disabled person would want or need. And uh, also, I don't know that this is even like a drop in the bucket. Disabled people are not a monolith, but these are things that if I'm doing, a needs assessment with a client, these are things that I'm thinking about. It might include things like, how do I increase my independence or my autonomy through things like caring for myself, managing my own finances, building necessary skills, um, growing my support system. So, who's on my healthcare team? Do I have a way to access that healthcare? Um, Often, when we're mapping this, telehealth is a really big part of that. I cannot tell you how many more people show up to their therapy appointments now that telehealth is a thing. And it's so great. No more are my clients stuck on the bus and 30 minutes late because the RTA just didn't feel like RTAing today. But also for people that are who struggle with invisible disabilities, if it is, a really tough day for someone mental health wise, but they want to go to therapy, but it's going to be too much of a lift to, you know, drive all the way across town to Cleveland Heights and come to my office and, oh, I have to talk to so many people. Telehealth, it's a really great way to stay connected. We're thinking about things like access needs as well. So not just transportation options and accessible environments, but also in those structural processes at agencies and practices. Are they accessible to people with disabilities? One that I didn't think about until I started working for myself is so I use an electronic health record. I'm sure that everybody does, but I use Simple Practice, and it will it. How do I explain this? It's not a very accessible electronic health record. It uses a magic link system for people to sign in. They don't just have a username and password. And so for people with any type of cognitive challenge, that is very confusing. It's atypical. Nobody else does that. It's just a Simple Practice thing. And so for some people, it just doesn't click. So in some ways, the choices that I've made in my practice make me inaccessible to some of my clients. And that's something to be thinking about. Is that something that I might want to change? Is that something that I can help a client to skill build or bolster? Do they need some sort of system to navigate what I've set up? And then there are things like tangible needs. So folks with housing insecurity, food insecurity, or financial insecurity, just like they were saying in the video, people who are disabled are often more at risk in these ways, often due to things like over policing and inaccessibility and just, um, you know, economic disparities. When it is difficult to hold down a job because of your disability, when your housing options are quite limited and maybe either taking a greater portion of your income because you have accessibility needs, then having that baseline stability that so often we take for granted is not a given. And lastly, we have inclusion needs. So these include things like accommodations at school or at work, um, different social accommodations. So, like letting your friends know this is what my disability looks like. If you're comfortable, if you have that support system, if you have that rapport with those people, as well as recreational inclusion. A big one that I see too is around folks with chronic illness who would consider their chronic illness or their um, immunocompromised status a disability, whether or not masks are a part of gatherings. So, for example, there's a community center here in Cleveland Heights where they will advertise masks encouraged or masks not required, just depending on like who's the target population for whatever event they're holding. It's great to have that information ahead of time, but for some folks that are immunocompromised and have greater awareness since the start of the COVID pandemic, that might mean that they can't go to, scrapbooking night at the community center, which is a bummer. Um, all of this, like thinking about accommodations, is also really relevant to the mental health professionals in the room because if you haven't already, it's likely that you will get a request to help someone with their reasonable accommodations. And in my opinion, it is within your scope of practice to do so. If we are the treating mental health providers, then we have that ability. We have that knowledge that maybe a primary care doctor wouldn't have. Certainly, someone at an urgent care wouldn't have. So, again, to be thinking about how does the mental health that I am treating impair that person at school or at work? And if I partner with them, if I really listen to how that shows up, what accommodations might they need to be successful in those places to move closer to their goals? And lastly, these are core values at the center of the mental health professions, but they bear repeating. Folks with disabilities need respect, they need dignity, they need our advocacy for people who are not disabled to step up, and they need empowerment to be the ones driving the bus, to be making the decisions about their own lives. So I said we were going to end with some resources before we break for questions. I would be remiss if I did not mention NAMI and what a wonderful resource they are. I cannot tell you how many clients I send their way, and no, they didn't pay me to say that. But they have an awful lot of resources for folks with severe mental illness, as well as, caregivers and loved ones as well. Specific to like the Cuyahoga County, greater Northeast Ohio area, if you're outside of Cleveland, Cuyahoga County has an Aging and Disability Resource Center. I linked it in this presentation. I don't know if these slides are going to be accessible, but I can also drop the link in the chat or you can Google it. It was the first search result. But they are awesome. You can call there as a social worker or mental health person with your client or on their behalf and get information about what resources they are eligible for. And in Northeast Ohio, we also have a cool coalition of disability organizations. And this is an organizing group that does both advocacy and what's the word that I'm looking for? Political organizing for people with disabilities. So they are a cool one to check out if you're looking for more grassroots resources or if you want to get involved on that level. Their coalition has a lot of ways to get involved. So we have about 10 minutes. And first off, thank you guys for being such a wonderful audience. Do you have any questions for me, for Peyton, for anybody?
And I'm going to go ahead and stop the recording.